it. Perfect. All right. Hello, everybody. Okay, we'll give everyone a few minutes since we're just shy of 4 on the West Coast before we get started. And I'll go ahead. I'll go ahead and post the workbook in the chat. Yes.
Yeah, I didn't see it.
Okay. Oh, you know what it is? It was in the backstage area. So everyone, there's a chat. Make sure you toggle. It says 2, and you can do to host and panelists, everyone in backstage. Make sure it's to everybody, unless you want to message just me and Susan. Okay. How has your day been?
Mine's been great.
Mine too.
Busy.
Yeah, it's been a productive week. We did another webinar this morning on we had this drive-in on progesterone, so continuing the theme for the day.
Continuing that theme, exactly. Okay. So.
All right, well, why don't we go on ahead and get started? So I'm Katya Black. I'm one of the founders at MedBio. Thank you guys for joining today. We're very excited to have Dr. Susan Lavelle with us to teach a class on perimenopause. So just a couple of admin housekeeping items. There's a webinar chat. We posted there the workbook for today. Afterwards, we'll also share out the workbook again and then the recording of the webinar so you guys have it. And then if you want to chat with everybody, feel free to post within the chat. Make sure you have it set to everyone. And then there's also a Q&A chat. You can use that if you have questions as they come up. You can either put them in there or you can put them in the chat function. Interesting. So, okay, you don't have the toggle on there?
I have a toggle, but it's not.
Oh, you know what?
Chat.
Try now. It looks like there was another setting I had to change.
Got it.
Okay, perfect. So with that, I will pass it off and we'll get started.
Wonderful. Okay. I'll have to always make sure that you can see my chat, number one. I mean, you see my screen, number one. And I just want to make sure that I can also see the chat. And then we will get going. Okay. So this is session 1 of the the talking about perimenopause. And the first session, we're going to be talking about understanding it, the physiology and the symptomatology. So I want to just say to everyone, anyone here today, is this. We want to know if you're confident or not. And please start putting this in the chat. Now, this is a woman. She's 47 years old. She walks into your office. She's sitting across from you right now, and she's in tears. She's in tears because she can't sleep anymore. She's in tears because she's snapping at everyone, both at work and at home. She feels like she cannot eat, one thing off of her diet without gaining 5 pounds. She's just frustrated. And so the whole question that I want to start asking you today is, do you all feel confident in managing these patients? So the very first question, do you feel confident on a scale of 1 to 10 in explaining perimenopause to people, to your patients. You put that in the chat, and hopefully I can see that chat again. Let's see. Just gonna pull the chat out. Okay, maybe 3 or 4, something like that. 4, 7. I'm loving that 7. Okay, so you, and do me a favor, would you all share with me again? Can you see my screen still? Okay. Yes, 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 yes. Wonderful. Okay, wonderful. So now I can see the chat and I can see you. So my second question for you is, how confident are you, 1 to 10? 10 is absolutely in using the straw plus 10 criteria for staging perimenopause. Put that one in the chat if you would. So I got yes, 3. Okay, this is about straw plus 10. So first of all, you got to know what it is, right? And then 2, you have to be comfortable using it. That's number 2. Good. So we've got some things we can start with today. Number 3, how confident are you in understanding the hormonal changes in perimenopause? 1 to 10. And there are quite a few. Ooh, Conchetta's got a 9. I love that one. Okay, so a lot of people are confident with those hormonal changes. And finally, with recognizing the full spectrum of everything that goes through perimenopause. So that woman who's sitting in your office or sitting in your clinic or your spa, wherever you are, how confident are you with understanding all of the symptomatology that she might be experiencing in perimenopause? And that's the last one I have for you all. 5. Okay. So 2, exactly. Kind of all over the place. And so we're going to be talking about a lot of things today. Do not worry about all of the things that I'm going to be sharing with you. You will get the download of you'll have a PDF, but you'll also get all of the slides. And so you can go over them as much as you want going forward. Because the main thing is that it's really about repetition. It's not about slamming everything into your head right now and trying to walk off completely confident in everything. Okay. So briefly, I just wanted to introduce myself. I am Dr. Susan Lavelle. This is my 3rd career. My first one, I was a professional dancer, ballet dancer, traveled around the world for 17 years. Then I went into what became my love for the next 22 years, which was plastic surgery. And talk about transforming people from the outside in. Love doing it, But at some point I got to the area where it wasn't enough to help them just change from the outside in. And I had my own health issues, which did start kind of around perimenopause. Went through my own health issues, and then I changed from going into plastic surgery into what I do now, which is lifestyle health. So helping people, helping companies, helping organizations understand how their health impacts everything, their productivity, their profits, because a lot of companies, that's all they want to hear about, but also how they can actually live the best that they possibly can. And that is what I do today. So our learning objectives for today, we've got 4 main ones. Number 1, we want to define perimenopause because there's a lot of questions about what it actually is and distinguish it from menopause. Very simple. Number 2, we want to understand straw plus 10 and how it's used now. It's not perfect, but it's the best that we've got right now to be able to stage perimenopause. 3, we want to explain the hormonal, neuroendocrine, and metabolic changes that are happening during this stage. And then 4, recognize all of the symptoms, or at least a good portion of the symptoms. Now, why does this matter? Why do we care about perimenopause? 2 billion women in the world are going through perimenopause and will spend, more than half of their life, about a third of their life in perimenopause and menopause. 2 billion women. So that's a lot of women, okay? Misdiagnosis is common, and that's a problem. Is there a manual or something you download to make notes? Yes, there is, and we'll upload it again so that you can download it as we're going through. Misdiagnosis is common, and we'll be focusing more on this in the second session. We'll be looking at all of the mimics of perimenopause, and there are a lot, unfortunately. But the main ones that we see: thyroid disease, depression, And so many women get put on antidepressants when really what's going on is they're going through perimenopause. And if we manage that, we wouldn't have to put them on antidepressants. And then early dementia, that's probably the worst. And how does it feel? These women are coming to you and they're saying, I can't remember. I walk in a room and it's gone. And they start to think that there's something wrong with them. And there isn't. That's what we need to know. And then there's a medical education gap. 20% of medical schools, it was worse when I went years ago, but even now, only 20% of schools actually teach about perimenopause and menopause. Okay. And this is a massive gap. Our clients know it, our patients know it, and we need to fill that gap and help them. Okay. So, first, what we're going to be doing really quickly, for those of you who either didn't learn it or learned it a long time ago, like I did, we're just going to do a really quick menstrual cycle recap because you need to know what the norm is before you can start thinking about, well, what's starting to change. So, number one, in the follicular phase, there are two main phases. As we see, the first 14 days in a typical 28-day cycle. The first 14 days are the follicle. The second is the ovulatory or luteal. Okay. So in the first section, FSH, follicle stimulating hormone, which comes from the brain, starts to rise slowly and starts stimulating that follicle to grow. Okay. Then the dominant follicle. So there are lots of follicles. Eventually, one follicle becomes dominant. This is, going to be the egg that can be fertilized, starts putting out estrogen, and that's helping to thicken the endometrium. And when that estrogen that's being put out by the mature and dominant follicle rises, it triggers the LH surge right here, luteinizing hormone. Okay. And that's when ovulation happens. So now we go into the luteal phase for the next 14 days. The follicle becomes the corpus luteum and starts making progesterone. Progesterone is going to stabilize the endometrium, and if we can, it will suppress further LH and FSH. So we don't want to keep developing follicles and making them bigger. Once we've decided we have a follicle and it's making progesterone, we want to shut off all that was happening before. And if no fertilization happens, both estrogen and progesterone decrease and menstruation starts. And we start it all over again. So brief recap so that we can have that information as we're going through the rest. If you look at all of this quickly, we saw what happened with FSH. It rises, has that peak there. Temperature rises, and that's why we can sometimes look at our temperature during the month to see when we ovulate. Estradiol goes up and then has another little poop. And then finally, progesterone is pretty low in the first follicular section, and then will rise and then fall if the patient doesn't become pregnant. Okay. So I'm not going to go through this one. You'll have that as well. It's really just going into detail about what's happening in with those particular hormones. So let's get into the straw plus 10. So this is actually the second consensus that happened in 2012. 10 years prior, they had the first straw. They came up with a second one for a specific reason. The first thing was that they wanted to define specifically what perimenopause was. And it is the transition period directly before and after the final menstrual period. Okay, that's it. That is what perimenopause is. And straw plus 10 staging really kind of simplified a lot of all of the information that we had about what was perimenopause, what wasn't. It says three things. And if you take nothing else away from straw plus 10, this is it. The early transition stage is when the cycle length changes more than 7 days. So if you're regularly 28 days, 28 days, 28 days, and all of a sudden you're 20, let's say we're 20 days, because that's less than 7, or if you're more than 7, when it's changing more than 7 days on either end. Late transition is when you don't have any period for more than 60 days. Okay. And then menopause is literally, and this is the only definition of menopause, is when you have gone 12 months without a menses. Boom. If you go 11 months and 3 days and then you have a period, guess what? You start all over again. Okay. So this came from the straw plus 10. It's really kind of it looks like there's a lot going on, but it's really relatively simple. If you look at the at the top rather, you have the stages. It goes from -5 to +2. It's got, and that starts with menarche. So your first menses is here. You've got all of your reproductive age. Then you start the menopausal transition. Your final menstrual period is right here. That is point 0. That's it. And then everything after that is postmenopause. Okay. So the the things that changed, we had some new biomarkers, and we'll talk a little bit about these three. The AMH, you may have heard about that, anti-Mullerian hormone, inhibin B, and the antral follicle count. So I know, like I said, I'm throwing a lot at you, but it's important, big, and you'll understand how you can quickly start staging people so that you'll understand where they are and what to expect. So we talked about FSH and LH, and we will be getting into estrogen and everything. But AMH is made in the smaller follicles in the beginning of that reproductive cycle. Okay, so the more follicles you have that are still there through your reproduction, the higher your AMH is going to be, which means as we get older, our follicle count starts to lower, and therefore our AMH will also lower. Inhibin B is actually made by the more mature follicles in that follicular stage. So if you can imagine, as we start to get older and we're not making as much estrogen and we're not having more mature follicles, we will have less of inhibin B. And so that one actually starts to come down sooner. And the last one is really just an ultrasound. You're looking at how many follicles are in the ovaries. However, it's simplified bleeding. Just like I said, more than 70 days, more than 60 days, not bleeding at all. Very, very simple. Okay. It made it more applicable to many more people. Okay. But it also realized that there were some problems, and there still are some problems. So it's difficult to stage people with, for instance, women who have PCOS or POI, which we're going to go into, premature ovarian insufficiency, or surgical menopause. How do you put them into this staging when the main criteria really is the menstrual cycle? So how do they fit in? So we understand there are still some gaps even in this staging, but the main thing is, what is their menstrual cycle doing? That's the most important thing. I like this one perhaps a little bit better because it gives you a better feel for the transitions, right? So we got the transitions here, the reproductive. So this is when you first start and when you're in that reproductive stage. The transition is here, okay? Remember, FMP, that final menstrual period, that is the point, the breaking point. Everything after that is menopause. Then you've got early menopause and late, okay? So what do the hormones look like when we're doing all of these transitions? Estrogen, which is going to fuel a lot of the problems that we have, is going to be erratic. If nothing else, just remember, it's up, it's down, it's back and forth. It's not a steady decline like a lot of the other hormones that we're looking at. Progesterone, in the luteal phase, that deficiency begins long before we're even aware of it. So that's one thing to look for. Sometimes we'll see women with nothing else, no other signs of perimenopause, except the fact that their progesterone has started to decline. So keep that in mind. And we're going to be talking about the issues and the symptoms that can happen with low progesterone. FSH rises, okay, but it fluctuates. And you can't use that as the only criteria to diagnose perimenopause because it's up, it's down, same way that estrogen is. And then finally, AMH, the anti-Mullerian hormone, that is the most consistent it's highest in the early reproductive years, and then it declines in a pretty steady fashion. Okay. So unfortunately, this woman may look like this. We want to know, why are they feeling this way? And they may ask, is it that I'm low in estrogen? Well, the main thing is it could be low, it could be high, especially when in that perimenopause age eight, that perimenopause transitional period. Okay. Um, this is not exact numbers, but I just wanted to give you an overall view of what's happening. So as we see, FSH starts, kind of starts around here. And then as we get older and go through transition and go into late menopause, that rises. Why? It's trying to stimulate the body to make a mature follicle. On the other hand, we have estrogen, which and unfortunately it goes up a little bit in early transition, and it shouldn't even be a smooth thing coming down. It's more like up and down and up and up and up and down until we get to late menopause where it evens out. Then we have progesterone, which starts a little bit earlier and is just low and completely goes lower as we go along. And then finally, AMH also is low, starts a little higher and then gets lower. So as I mentioned before, we do have these other markers, the AMH, the inhibins, and the antral follicle count. There are several studies that talk about how valuable they may be for looking and diagnosing perimenopause. Of the three, AMH is probably the best. However, it still has its own issues. And therefore, as I mentioned before, straw plus 10 is it. Period. How you are going through menses is really the defining characteristic of perimenopause. Okay. So let's look at briefly when the clock runs fast. Okay. So what is perimenopause? As we already know now, it's the transition period leading up to and shortly after menopause, typically ages 45 to 53. Menopause is that 12 months, remember, 12 months of the day, no period, and then everything after. Early menopause, here's where we start to differ. Early menopause is when it occurs before age 45. And then finally, premature ovarian insufficiency is ovarian failure before age 40. So you've got intermittent function and elevated FSH. Remember, because it's FSH, the brain is trying to stimulate the body to make follicles, but if it can't, it's only going to get higher and higher and higher. Okay, so our job in POI, premature ovarian insufficiency, is number one, to recognize it and confirm the diagnosis, because this is actually can be tragic. So the first part that we're looking at is no periods more than 4 months before age 40. Number two, the FSH has to be elevated on 2 occasions at least 4 weeks apart. Why? Because if it's in, if they're in if they just happen to be in early menopause, then maybe the FSH is going to vary, because estrogen's varying. Okay. Low estradiol. Okay. And you want to rule out things that could look like premature ovarian insufficiency, pregnancy, right? If you look at these numbers, no period for 4 months before age 40, she could be pregnant, right? Thyroid issues, high prolactins, and just amenorrhea. What if they are an elite athlete and they just, they actually work themselves into a point where they don't have a menses? You want to take out those secondary causes first. And then we want to look at some of the common reasons they develop these. Number one, autoimmune issues, thyroid, adrenal, ovarian antibodies, genetic issues, iatrogenic. Did we radiate? Did we take out the uterus and the ovaries? We want to make sure, although I think we should know that. And then finally, more than 70% are iatrogenic. Idiopathic, not iatrogenic, idiopathic. We just don't know why. Okay. And then what are the clinical implications? Because it's great to have information what's more important is how does it impact the patient or your client who's sitting in front of you? Well, number one, and probably the most devastating, we have that fertility loss. Spontaneous conception rates of only 5 to 10%, right? They're not ovulating. If you're not ovulating, pregnancy is nearly impossible. Okay. Bone density loss. Now we're starting to see, and we're going to get into these things, because if we don't have our hormones, especially estrogen and progesterone, earlier than we normally do, we can have issues. Okay. Cardiovascular disease and mood, cognition, and sexual health actually tend to spike even more so than a woman going through a traditional perimenopausal period. So, what do we do about that? We want to protect them. Okay. So number one, how do we actually manage this? You've got this woman. She is, 35 years old. How do you actually sit and talk with her? For her, hormone therapy is essential. It is not optional. And why is it? We just talked about the issues that they could have. Low estrogen and all the problems with that, low progesterone and all the problems with that. You want to continue this, and this is where we're going to go into more in this in the second lesson, but we want to follow this at least until they hit the age of natural menopause, which is around age 51. That would be the minimum. You can think about continuing even afterwards, especially when you start to learn some of the wonderful aspects of hormonal therapy. You want to use combined estrogen and progesterone. Studies have shown that just estrogen by itself can have some issues long term. So you want to combine them too. And as I said, we'll get into more of this in the second session. And you want it to be progesterone, not progestins. You want to screen for autoimmune and genetic causes. We just looked at that could be a reason for having these issues. You want to optimize their health, all of the body issues that could be impacted by these low estrogens, and offer fertility counseling. Okay. All right. Because PO, I didn't even say it's not it's not something that is just menopause. You want to feel that it is, you're not just telling them that, they're early menopause, don't worry about it. No, it's actually something that you need to understand and treat in an appropriate manner. So we're going to have a little quick, I'm not sure how we do breakouts here. We're going to do a little quick thing. First question is, we've got Maria. She is 43 years old, irregular cycles, and they're about 40 days apart. Okay. She's waking up at 3 a.m. She is drenched in sweat. She changes her pajamas. She can't get back to sleep. 10 o'clock, she's in an important meeting. She can't think about, she loses complete track of what she's trying to say and starts fumbling with her words. 6:30, she gets home. She made it through the day. She's exhausted, but she made it through the day. And now she's snapping with her partner because they just looked at her. And 9:30, she's getting ready to go to bed. And she, like many of our patients and clients, is starting to wonder, what is wrong with me? And so I want to ask you, we won't break out, but let me ask you, how would you stage Maria? Okay, on that straw 10, where would you put her? And if you downloaded the PDF, you should have that. You should have the staging towards the back. Okay. And maybe what I can do is you don't. Okay. You raise your, yeah. We'll raise that one again for you guys. Okay. All right. And actually, I am going to put in yet another. Okay. So I put in a compressed one that actually does have the staging in the back. Okay. The first one I realized did not. So you'll have the staging there. Okay. And that should help. So let me just kind of say, I'll give you some hints as well. So remember, we've got that picture with all of the staging. Um, what might be easier, and I am going to pull this back.
And actually, just really
Okay.
quick, if anyone
Yes.
has questions, if you raise your hand, I can allow you to speak so people can ask questions live. So don't be shy. You can
Yes,
definitely use
please
the
do.
chats or use the Q&A, but I can also we can allow you guys to talk. So please chat.
Yes, please do. Please do. Okay, so I'll put this one up there in case you couldn't find it in the other one. All right. So this is and so we you said that her periods are more than 40 days apart. Um, and she's not sleeping, she's irritable, and we wanted to say where she is. Okay, so we've got it around here, right? We know she's in the menopausal transition. I'm going to switch back into where we were. Okay, let me share that. So I see I've got one person who said, who was good with putting in, okay, let me pull that all the way down. We got a -2. Anybody else want to kind of go in on it? Just take a wild guess. This is like this is here for this is for us to learn and to just go through. All right. So let me go to everyone again. So the answer is perimenopause stage 2, -2. Remember? And the reason for that is even though she has vasomotor symptoms, even though she's waking up hot, her menses are less than 60 days apart. So remember what I said, the primary criteria for perimenopause and staging is what is going on with their menstrual cycle. For her, it was more than the 28 days, but it was less than 60. So now she is in that -2, perimenopause stage -2. Okay. And really, the reason that we want to learn this is because this way we can talk with providers across not only the nation, but around the world, and they'll understand exactly what we're talking about. Okay. So, what does the symptom spectrum look like? And this is now someone coming in to see you. So number one, vasomotor. And normally when we start talking about perimenopause, what do we often say? We're like, oh my goodness, the hot flashes, the freezing, all of that. You can't regulate your body. 30% of people are coming in with that complaint. The night sweats, the flushing. Sleep disruption, though, is number two. Okay. So they insomnia, or they're waking up at 2, 3 o'clock in the morning and they can't get back to sleep, even if it's not because of flushing. They just can't sleep well anymore. Mood and cognition. So anxiety, depression, and brain fog. And we're going to be going into why each one of these symptoms starts to pop up in perimenopause. Genital urinary, okay, vaginal dryness, painful sex. And then finally, musculoskeletal, 10%. But guess what? If you're suffering with joint pain and stiffness, you feel it. Okay. So, what are the things that actually can make them worse? Number one, increased stress. Stress is a killer. Increased BMI. I'm going to talk about why that happens, and ethnicity. And we'll talk about the Swan City towards the end as well. Okay. So now we have this matrix. We've got stress, we've got sleep, and we've got gut health. And those three things can really impact what's going on with us as we're going through perimenopause. So the first one, chronic stress, right? As I mentioned, now we're seeing increased cortisol. That's going to impair your getting rid of excess estrogen. Okay, and we're going to really go into that because that's one of the newest areas of perimenopausal study that's come out now that has such an impact. The second thing is poor sleep. It's going to disrupt our cortisol rhythm and it worsens those hot flashes. Plus, you feel bad, you know? And then gut dysbiosis. So when our gut is not working well, and I'm going to show you that in a second as well, it's going to reduce how our estrogen metabolism actually works, right? And then the result is you're going to suffer more. Your clients are going to suffer more. And the point is, it's not the reason I put these things here is that lifestyle, which is why I'm so adamant about teaching, first of all, understanding the physiology behind it, but then teaching what you can then teach your patients and clients to do daily to make a lot of these symptoms either disappear or reduce significantly, even without medication. So let's do a quick review of the gut brain axis. And I share this when I teach this one at A4M. It's a wonderful thing. The reason is a lot of times our patients and clients understand that connection even before we do. Okay. So how many of you have heard these someone say, I've got butterflies in my stomach, or I have a gut feeling about that person? It's because there really is a gut brain connection. And it's our brain, the way our brain works is the way our emotion works. Okay. And it starts really with that vagus nerve. This is the nerve that goes from the base of our skull and wanders. That's where the vagrant part, vagus nerve from, wanders throughout, innervating our heart, our lungs, and our gut until it goes out. It's got our hormones, the steroid hormones. It's serotonin. 70% of serotonin is made in the gut. So if your gut's not working well, you're not making serotonin well either. Serotonin is huge for the way we feel and how calm we are. It's also our GLP-1s and our GIP. If our patients are interested in weight loss and our gut brain axis isn't working well, they're not gonna lose the weight. Okay. It's our immune system, systemic inflammation, and it's all of the metabolites made by the gut. The short chain fatty acids, vitamin K, and the B vitamins. So let's start talking about some of the hormones now. Estrogen, of course, is probably the most important, the most read about, and the most studied of all of the hormones as we're going through perimenopause. And it affects literally from the day we're born, okay, until the day we die. So, what are some of its effects? Now, just like, Goldilocks and Three Bears, we want everything to be just right, not too hot, not too cold. We want it to be just right. So, what does it look like if estrogen is low, right? We've got low levels for whatever reason, okay? Osteoporosis risk goes up. Cardiovascular risk, of course, our menstrual irregularities. That's what perimenopause is all about. Maybe amenorrhea altogether, infertility, cognitive decline, and vasomotor changes in menopause. So it's not so much low, but it's actually the up and down aspect of estrogen that's causing this. And then finally, vaginal atrophy, which can be painful, just painful. Okay. But what about when it's on the other end? Then we have too much. And if we remember from just when we looked at the cycle, what is one of estrogen's biggest jobs? It's to help proliferation, right? It's helping cell growth. So if we've got too much of it, ooh, look at what can happen. Breast cancer, endometrial hyperplasia and cancer, PCOS, ovarian, we're seeing that, if we've got too much estrogen and the wrong type of estrogen, we're actually having growth that we don't like and don't want. Weight gain, blood clotting events. And when we talk about next session, we're going to be talking about that fine line between estrogen therapy and the risk, one of them being clotting. Okay. And even men will struggle, too much estrogen in a man, big breasts, gynecomastia, and it actually will reduce their testosterone, okay? And their risk for heart disease goes up. So this is a hugely, and as I mentioned, it's really one of the newest studies that we're looking at now, the estrobolome, which is how the estrogen is metabolized in the liver and the gut and everything, and what happens. So over the course of our lifetime, estrogen is made in three places: our ovaries, our adrenals, and adipose tissue. Remember that. When we go through menopause, ovarian, production pretty much plummets to zero. And then we're mainly in the adrenals and adipose tissue. That's why the more adipose tissue you have, sometimes the higher the estrogen levels you will have. So typically the estrogen that's made goes to the liver to it has a little binding protein put on it. See that little binding protein there? It goes on it. Now it's conjugated. This then allows it to be excreted easily into either the kidneys or out through the gut, because it's a water soluble product. When it goes to the gut, though, okay, our gut has some bacteria, and we'll talk about what increases that bacteria, that makes beta glucuronidase, which is an enzyme. That enzyme then plucks off that binding protein, and now it is a deconjugated estrogen. It's no longer water soluble. It no longer can go out through the GI system. Instead, it goes back into the blood system and is recirculated in the body. So if you can imagine, the higher the beta glucuronidase, the more deconjugation, the more of that estrogen is going to recycle in the body, the higher in that, the estrogen levels will be. Does that make sense? I hope so, because it is really important. So briefly, progesterone's effects: high, low. We don't want high, we don't want low. I won't go through so much on these, but we will look at this anyway. Irregular cycles, anxiety, irritability, weight gain, low libido, if it's low. On the higher end, which we're usually not going to see in perimenopause, but we can have issues with high as well. So briefly, beta glucuronidase, the main thing is it's going to allow increased absorption. It will result in estrogen dominance and dysbiosis. So excess estrogen, how do we get that? Stress. Remember what I said, stress impacts everything. Crap food, chemicals, oral contraceptives, body fat, like I mentioned, and low thyroid. Those are just some of the ways we get excess estrogen. Plus low progesterone, so higher versus low. How do we get low progesterone? Stress, number one, high cortisol, perimenopause, which we're talking about, toxins, plus poor detoxification. Stress will do that. Constipation. So talk to your patients about constipation. They need to be going to the bathroom and relieving themselves at least 1 to 3 times a day. Talk to them, ask them specifically, because they're not going to tell you. I'm going to say that, one of my patients thought it was normal to go to the bathroom once every 2 weeks, once every 14 days. She thought that was normal because no one ever told her that it wasn't. Okay. So what does this lead to? Estrogen dominance. So the estrogen doesn't have to be higher lab wise, but in comparison to progesterone, it is out of balance. And this is why our patients are struggling. Okay. So I won't go too much into this particular slide. It's going through all of the roles of estrogen and progesterone for the various things throughout. We're going to go into each one of those in much more detail. So how does our metabolism start to shift when we start going through perimenopause? when we start losing that estrogen. Number one, we start seeing lower insulin sensitivity. I'm going to show you why that happens and how it happens. We see increased visceral fat, visceral, not subcutaneous. We see decreased mitochondrial efficiency and decreased muscle mass, sarcopenia. So premenopause, our muscle mass is pretty good. Visceral fat's a little lower. Postmenopause, it flips. So same weight, right? Exact same weight, it changes the body composition. So that in and of itself is enough to make it more difficult for someone to lose weight if they are trying to. Okay. So this again is something you're going to see if you haven't experienced it yourself. When you start having declining estrogen, you will have insulin resistance and increased visceral fat. So not the subcutaneous fat, not the fat that is, it's unsightly, but it's not metabolically active and it is not dangerous to us. However, visceral fat is around our organs. It's internal and it is very, very, if you're comparing the two, it's much more impactful on our cardiovascular health and everything else. So how does this happen? And this is a slide that I share when I'm talking to my lay clients about insulin sensitivity and insulin resistance. So just imagine all of these cars are the blood sugar molecules, and you want to get it into the center of the cell where the mitochondria are so it can feed. But if the cell is resistant, they just bypass. And if they bypass, all of those molecules are bypassing, they've got to go somewhere. So where do they go? Places like the liver. That's how we end up with fatty liver. It goes to other parts of the body, right? So here's the paradox here. They are exhausted because you saw that picture, the blood sugar is not getting into the cell where it needs it to make ATP. Instead, it's getting stored other places where they don't want it and their bodies can't access it. So they're tired, they're feeling more and more fat and they can't access the energy that they need. So this is kind of what it looks like. And this is actually a cardiac mitochondria. That's what they look like under the electron microscope. So what happens here? They've got estrogen receptors everywhere, but especially in skeletal muscle, the brain, and the heart. And when you have that lower estrogen, the mitochondria don't work as well, less ATP production. And that makes it harder for muscles to work, right? I'm not going to go into all of the NF kappa Bs and everything, but the main thing is you have less mitochondria density and they start to kind of chew up on each other. Actually, and they don't chew up on each other well enough. So now you've got more of those damaged muscle fibers sitting around. And then finally, you've got the energy deficit, because now remember, the blood sugar is not getting into the cell where it needs to be. You've got more inflammation, and now you can't build muscle, right? Okay. So the result is that you increase that sarcopenia. They cannot make the muscle, loss of lean muscle mass, strength, and metabolic flexibility. So it's kind of like this revolving door where they're trying to lose weight, but they can't access the muscle. They can't access the energy for their muscles, and then their muscles start breaking down more. So we'll see again, second session, what we can do to reverse this. What does it look like for bones? Okay, so estrogen's role, it acts on bone cells. Okay, it's got receptors for estrogen are pretty much everywhere. Okay, that's something we really, really need to understand. And if we're seeing that these receptors are almost everywhere, what is it saying to us? That is that important. Okay, we need estrogen. It supports bone formation and keeps them from resorbing. Progesterone is going to stimulate the actual osteoblasts, the ones that are making new bone. Okay, and it works with estrogen. So when both of them start getting low, when the estrogen is low and the progesterone is resorbs, but you're not forming. And so you start having that risk of osteoporosis. Now start thinking about, remember, we talked about the woman with POI, premature ovarian insufficiency. What's happening with her? She's lost both of them long before she should have. And so her risk of bone osteoporosis actually increases significantly. Our next one, what does it look like inflammation wise? Okay, so again, so let me ask you all, how many of you, when you went to wherever you went to study, did you learn about the interleukins? Would you put that one in the chat? The ILs and the IL ones and twos and things like that. If you would put that one in the chat and just let me know. Yes. Okay. Stephen says yes. Anybody else? Okay, so yes, a little. Okay, I'm not going to be going into them other than to say what they are, but I'm just going to say when I went to medical school, there was interleukin 1, and we were like amazed when they came out with interleukin 2. Okay, so that's just giving you an idea of how long ago I went to medical school. Well, I think we're now up to like 20 or something crazy like that. So, so Naya, you should come up and start teaching this, right? So these estrogen is going to suppress these. These are the inflammatory, the ones that we know really are inflammatory. Okay. Normally, progesterone acts specifically as an anti-inflammatory and neuroprotective hormone, and it downregulates again those pro-inflammatory cytokines that we just talked about. It also works in the brain. Okay, so it's going to work to stabilize the glial cells, and that helps with the blood-brain barrier. So when both of them are declining, more stress, more production of the cytokines. So you've got weight gain, fatigue, joint pain. That's where the inflammation is coming from. Okay. Next one that we want to talk about are the immune changes. All right. And this is a reason why you may start to see more women in that perimenopausal age coming with their first diagnosis of autoimmune conditions. They may have been sort of okay throughout their lives, and they start seeing issues like this going forward. So again, estrogen is helping to maintain our immune tolerance. Okay. Progesterone increases the anti-inflammatory. So the same way that we have inflammatory cytokines, we have anti-inflammatory ones. Interleukin 10 is one of those. Okay. It stabilizes your mast cells. So think allergies. Okay. And then it modulates the antibody production. So without them, you don't have that immune tolerance, and you're going to start seeing more of those flares that I was just talking about. Okay. Lower immunity all around. Let's then go into the brain and how it's affecting here. So estrogen, serotonin, dopamine, and norepinephrine, those are the big ones. Those levels change with estrogen. And that's one of the main reasons why women struggle as they're going through perimenopause. Remember, those estrogen levels are going up and down. It's not a nice, clear decline. It's bouncing up and down, right? You've got hot flashes from the hypothalamus. So you've got a set point, and actually the set point of high and low gets narrow when estrogen lowers. And so, eating that chili pepper or that hot, a hot spicy meal, which may have done nothing before, may now trigger a hot flash because that set point is so much lower than it used to be. And unfortunately, there is a 2 to 4 times increased depression risk during menopause. If you take, again, things to really take away, it's not in her head. It's in the neurotransmitters. Fix the problem. Don't just see someone, who's coming in that perimenopausal age and say, oh, she's sad, give her an antidepressant. Look at what's going on, fix what's going on, and then if that doesn't fix, then we can think about something like that. So what does the brain look like on estrogen? Number one, as I mentioned, it stimulates and enhances serotonin, which is our mood regulation, and GABA, which is a calming neurotransmitter. So, when estrogen fluctuates, so do our mood and anxiety. So, if you remember Maria, what was happening to her? She was getting home at night and just flying off the handle. Very, very possibly that was what was going on. It's the hippocampus. So an area in the brain that is, or neuroplasticity. So this is your memory. This is how you can pull back memories. Remember, the woman who walked into your office and is in tears because she can't remember things anymore. A lot of that can have to do with the hippocampus and estrogens lowering that neuroplasticity. BDNF, brain derived neurotrophic factor, is how your brain survives. It makes new neurons and has that cognitive resilience. And if you have lower levels, reduced flexibility. And then finally, the mitochondria. Remember, mitochondria are crucial for energy no matter where they are, and they're everywhere, right? That's what makes ATP. And so we want to optimize that. Without it, those neurons are going to struggle. And eventually, essentially, this is what brain fog comes from. It's not an imaginary thing, it is physiologic. You've got decreased estrogen, decreased serotonin, GABA, decreased BDNF, decreased mitochondrial efficiency. So now you can't think, you can't concentrate, you can't think of your words, and you have these brain, your brain just goes, and you wonder why. This is why. Okay, let's get into the vasomotor stuff. So 60 to 80% of women are going to have them, hot flashes. And actually, it's interesting, it starts with cold. They will often have cold sweats in the middle of the night, which then change into hot flashes and hot flashes at night. The median duration is 7 years, but can be a lot longer, especially with certain ethnic groups. And as I mentioned, with obesity, remember, fat is metabolically active, period. The more fat cells there are, the more metabolically active you will be. Smokers and those with African American ethnicity. Those three groups in general tend to have more and longer periods of those vasomotor changes. So, what happens here? As I mentioned before, it's changing that set point. You had a narrow set point, it's now no longer narrow. Let's get into the GU and sexual health. So, what happens here? Vaginal dryness and discomfort. We have lots of creams and things. We can do probiotics, we can do topicals. Well, we'll get into that in the second session. But painful intercourse, and this is something that a lot of women struggle with. And again, the same way they're not going to tell you and just burst out with, oh, I'm constipated, they may not tell you this either, right? Recurrent urinary tract infections, and maybe for the first time in their life, they start to be a little incontinent. Not really horrendously so, but more stress. They'll cough and kind of have some issues where they never had before. Okay. Sexual health. They now have a decreased libido, and it's multifactorial. Okay. It could be their hormones, it could be their mood, it could be their relations. Things are changing, right? And like I mentioned, it's often missed. It's often missed or not asked for because they're not telling. And so we have to remember to ask. Don't be afraid. Don't be, take them up on it. Have them have that discussion with you. Okay. Mood changes, anxiety, worrying, ruminating becomes a lot more prevalent. Okay. Depression risk, and these mood changes, I don't know how many of you will sometimes feel like this is you, right? Or your patients, and it's not you. It's like you become this person that you have never been, never really wanted to be, but there's a reason for it. Okay. Estrogen, as we mentioned before, modulates these really calming key neurotransmitters, serotonin, dopamine, and GABA. When that drops, we start seeing these things will start to, again, go up and down. The GABA declines and the dopamine falls. So those three are so important as far as your mood and how you make it through the day. Let me ask you, anyone, well, we'll ask in just a second, what you're actually seeing in your own practices. And then progesterone, because progesterone has a role as well. So it binds to GABA as well. Remember, that's the calming neurotransmitter, and it could actually be as calming as low dose benzodiazepines. Okay, so a lot of women who aren't sleeping well, take a look at what their progesterone's doing. And if it's on the low side, they may benefit from just a low dose of progesterone to help sleep. Those change, and then you have that wired but tired. Okay, they can't sleep, but they feel like, they're like this as well, but they're exhausted, wired but tired. Okay, and then finally we have that psychosocial, because it's not just hormones, right? A lot of what's going on during perimenopause, we've got a lot of women who are in that sandwich generation. They're taking care of their kids, but they're also taking care of their aging parents. And so they've got stress on both sides. Body image, you're now seeing a body that you never saw before. You know what I said? I mean, you're working out, you're eating the right foods, your clients, whoever it might be, and you're not seeing what you used to. You're not getting the results that you used to. And now you see why, with all the estrogen and declines. And then we start thinking about, like Maria did, what is wrong with me? And I'm here to say there's nothing wrong other than you're going through menopause. All right. Which is amplified by sleeping well, poorly, and all of the hormones. And then a lot of us got to where we are in life because we were perfectionists, because we took we took the steps to get where we just took steps that other people would never take to get to a point where we are. And because we are like that, because we have those perfectionist tendencies, we tend to be harder on ourselves as we're going through perimenopause. So the main thing is, let me ask you all now, which cognitive or mood symptom do your patients complain about most often? And I would love for you to put that one in the chat. What are you seeing the most out of all of the things we just talked about? Is it, anxiety? Yeah. Is it, I feel off? Yeah. Yeah. They don't feel themselves. But you know why? Because they're not themselves. Lack of concentration. Now you know why, right? You understand there is a physiological reason for why they're going through depressed. Yes. Yeah. Yeah. Serotonin, GABA, all of these neurotransmitters are first haywire and then they just plummet. Anxiety, brain fog, and irritable. Exactly. Exhausted. You now know why they're exhausted. They're getting more and more insulin resistant and their body's not getting the energy that it needs. Okay. Only personal experiences. Yeah. Well, hey, we are our own best clients or patients, right? Or we should be. But yeah, stress. Remember that one slide has got stress at the beginning of almost all of the issues. If you could do one thing for your clients, if you could just magically do one thing and just pluck out stress, boom, their lives would improve twofold. Okay. One thing, twofold. I hear a lot, I feel crazy. Yeah. Okay. Now, do you just looking at these things, these are reasons. Like I said, there's a lot on these slides. You'll get them, go through them again. But are you seeing why they feel crazy, why they're exhausted, why they're depressed, why they feel irritable, have brain fog, are anxious, and just feel off? Yeah, 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 exactly. All of these things are happening for physiologic reasons. Okay. So Here's the here's the next big one: sleep disruption. And I can't tell you how many women I have coming in, and they're on super physiologic doses of melatonin because they've been told, if I can't sleep, it's because I don't have enough melatonin. Let me go take melatonin. And yes, there are reasons to take melatonin, especially if it's low, but there are a lot of other reasons, especially in perimenopause, that are related. So number one, we have those hormonal fluctuations, up, down, all around. Cortisol, we know, that the cortisol increasing as melatonin is decreasing. It's usually 2 to 4 o'clock in the morning. They're telling you, I'm waking up, I can't go back to sleep. That's often why. So not necessarily just melatonin, but it could also be cortisol. Okay. Vasomotor, they're waking up, hot flashes, or they're having the night sweats, whatever it might be. Blood sugar, this is a huge one. Let me keep typing the. I want to make sure you have time to go through our little programs at the end. So it was interesting because a lot of us don't realize it. So we understand now we've got the insulin resistance, right? Blood sugar is not getting where it needs to in our cells. But there's also a lot of women who, because they're trying to, drop some pounds, and so they're not eating as much as they used to, and they're not really thinking about eating before they go to bed, because really you're not, we've been told so many times, don't eat and go to bed, which is true. However, one thing that you might want to do with people who might be struggling with their insulin or blood sugar is put a continuous glucose monitor on them for a couple of weeks. Now they can just get them over the counter. They don't have to have a diagnosis. Have them put that on and just see what's going on. The reason I say this is I had my daughter who would wake up in the mornings with headaches and just kind of foggy and just whatever. We put one on her, and her blood sugar was dropping down into the 40s at night. 40s. She didn't even realize it. Okay, so things like that will wake you up and definitely disrupt your sleep. Okay, neurotransmitters, we just went into those. Remember that if you look back on the neural things, tryptophan, which is, if you eat a lot of turkey day is coming up. Turkey is tryptophan, goes into serotonin, and if we're not stressed, that serotonin then goes into melatonin. Okay, that's the way it goes. So the more serotonin without stress, the more melatonin, the easier we'll sleep. Okay. Circadian rhythm. Sleep hygiene is huge. We're going to go into that next week as well. Inflammation and medical contributors. So obstructive sleep apnea, restless leg, thyroid imbalances, all three of these increase with women in perimenopause and menopause. Okay, and then as we just talked about, the psychosocial stresses. So I won't go too much into this particular slide, but what's going to amplify those symptoms? Inflammation, insulin resistance, high cortisol, cardiovascular health, and a sedentary lifestyle. Again, tell them, get up, move throughout the day. That's going to be huge. Okay, so how will you start advising your patients? Well, how do you advise them now? We know that these are some of the things that can influence, but how do you advise them now? What do you tell your patients? I heard about, you're exhausted, you're anxious, I feel off, brain fog. How do you now speak to your clients about how to start looking at perimenopause? Start thinking about that, because we're going to be doing we're going to go through 3 cases in just a bit. So start thinking, okay? And then finally, we have variability in cultural context. So the SWAN study, which looked at women across the nation, looking at the study of women's health across the nation, SWAN, saw, number one, as we mentioned before, African American women tend to report more severe and longer vasomotor symptoms. Asian women, on the other hand, reported fewer. And one of the things that they noticed was that social determinants actually will shape that symptom burden. So stress levels, work environment, dietary patterns, what you're eating, and access to healthcare were probably the biggest determinants out of all. And if you put it down here, you look at it this way. So African American women, higher frequency, longer duration, earlier onset. Caucasian women were kind of in the middle, mid or moderate frequency, but more likely to report mood symptoms and more likely to ask for treatment. Okay. And then finally, the East Asian women, fewer basal motor symptoms overall. And there's a question about whether it was the higher amounts of dietary phytoestrogens that made that protective role. So just keep that one in the back of your mind for next week as well. The most important thing, though, is to ask and don't assume. Okay, right? So we're going to do three quick cases. We're going to talk about what we might do with them. I'm going to put them in the chat. So our first patient is 34 years old. She's coming into your office. She's got 6 months of amenorrhea, fatigue, and new hot flashes. She's training for a marathon, but hasn't changed really in her weight or diet. Her pregnancy test is negative. Her FSH is 48, estradiol is 26, and she has a normal TSH. Family history of Hashimoto's thyroiditis. So, okay, so you've got it, 6 months of amenorrhea and all the other things. What stage of reproductive aging does this fit? And we'll take our time. Okay, you can pull that up in the, pull that up in the PDF that I sent. Okay. All right. So 6 or diagnosis. So 6 months of amenorrhea, fatigue, and new hot flashes. She's training for a marathon. FSH is 48. Estradiol is 26. Normal TSH. Her age is 34. Well, I'll put all three questions, right? What additional labs or evaluations are warranted? And how would you frame her initial management? I was hoping that this could be a breakout so you could talk among each other and kind of come through with some ideas, but let's just work it out together. So what would you say out of all of these things that I put in her history, what is the one most important thing that you need to know to help diagnose or stage her? Please raise your, oh yeah, raise your hand if you want to speak. Absolutely. So you can put it in the chat and I can't, can I see raising hands? No, I can't, but I'll let Katya unhook if she can.
Yeah, I can switch people to allow to talk if they want to chime in.
Perfect.
Yeah.
Perfect.
Or yeah, people are free to put in the chat, but
yeah,
don't be shy.
This is where we're learning how to do it. Okay. Like I said, just take a while, 6 months of amenorrhea. Okay. That is important. Okay, so let me rephrase that. I'll give you two. You've got the 6 months of amenorrhea. What's the other big important? That she's not pregnant. Yeah, exactly. She's training for a marathon. Okay, I love these. One other thing. Way up at the top. How old is she? She's 34, right? So if she's 34 and she's got 6 months of amenorrhea, we've got two things that might be going on. All right. She's young to not be having menses. Yeah, yes, exactly. So she's young, but she's also, and this is why I'm kind of giving you this, because it's not, none of these are going to be completely straightforward. I want you to kind of understand that there are nuances to anyone coming and sitting in front of you. Okay. You're not going to get the textbook, okay, this is this, this is this, this is this. You're going to get people like Sophia, who's 34, hasn't had a period in 6 months. Her FSH is elevated. Her estradiol is low. and she's training for a marathon. So the question is, number one, is it because of the training for the marathon? Right? Is that why she's not having a period? And if so, would her FSH and estradiol also be like this? So what we want to do here, number one, and we actually gave you a couple of things, right? We have a normal TSH, and for anyone who's in the functional or integrative space, you know that a TSH is not enough to determine thyroid function. But we're going to take it for today, all right, that's saying that that her thyroid function is normal. We have, however, that she has a family history of Hashimoto's thyroiditis. Okay. Remember when we looked at premature ovarian insufficiency, we saw that one of the things was that amenorrhea more than 4 months. You had to make sure that they weren't pregnant, which we said she has her pregnancy test was negative, and she's got this family history of an autoimmune condition. So the thing that we would want to say is, okay, maybe she does have POI, but maybe also it's the fact that she's training. Okay. I would ask, how long has she been training? Yeah, yeah. And what is her weight? Well, we're going to say her weight is normal. I should have put that one in there. Thanks for asking that. I'll change that next time. Her weight is actually considered good for an athlete doing a marathon. So the main thing that we want to know is, number one, her age. So she's too young not to be having a menses unless she's pregnant. There's something going on with her thyroid, or POI, or training, something like some significant training. So what we want to do is look at her FSH again in several months and see where she is. Okay. So if she's gone throughout that and it's still elevated, still what that low estradiol, then we're going to put her into that category of POI, premature ovarian insufficiency, right? And then if we have decided that that's the case, what will we want to do? That one I do want you to put in the chat. We've now decided, okay, we've ruled out all of the other stuff. We said, okay, she has POI. What is the first thing that you're going to want to do for her? With that one in the chat, or come off. Feel free to come off. Anyone? Okay. Remember, hormone replacement. Love it. Love it. Talk to her about hormone replacement. Why? Because she is now way before she should be, without good levels of estrogen, without good levels of progesterone. She needs these hormones for her heart, her bone, her brain, for everything, for her mood. She needs these hormones. Okay. So talk to her specifically about hormone replacement. Excellent. Excellent. All right. Looking at testosterone level 2. Yes, yes, for sure. We're going to be talking about testosterone next week as well. Next week is going to be packed. I'm going to just tell you right now. Yes, you definitely want to know what's going on with her testosterone as well. Love it. Okay, vignette number 2, Deny. She's now 50 years old. Okay. She's having increasingly unpredictable periods. Sometimes they're 3 weeks, sometimes they're 3 months apart. They're just flying all over the place. Okay. She has a heavy flow. She never really didn't when she was growing up, but now all of a sudden she's going through pad after pad after pad. She wakes up, oh, her heart's pounding. She's hot, she's living under the fan. Her husband's like having a heart attack because, well, not heart attack. Her husband's having a hard time because she's always hot. He's always cold. Is rough right now for them. Okay. Her FSH is 34. Her estradiol is 95. Okay. The questions with this one: which straw plus 10 best fits her pattern? So with the first one, that was kind of like it was a little bit of a trick because she wasn't really on the straw, but it actually points to why even the straw criteria is not perfect. Okay. So what straw plus 10? What are her primary symptom drivers, hormonal or otherwise? And how would you begin counseling her? Keeping in mind that we're going to go into really how you do this in detail next week. So, call it the 4 B's and H: brain, boost, bowel, and bones. I love that. I'm going to remember that one. Exactly. Brain, boobs, bowel, and bones. Yes. Bless your heart. I love that. Yes. So, where do you think Denai is? 50 years old, unpredictable periods, sometimes 3 weeks, sometimes 3 months. They're like flipping all over the place, heavy flow, having vasomotor symptoms, FSH 34, which is a little bit up. Estradiol is kind of up, not up, but it's not low either. Okay. Where would you put her? Number one, let's start the easiest thing. Okay. Easiest thing is, has she reached menopause yet? Yes or no? Put that one in the chat. Has she reached menopause yet? No. Okay. So we got that, right? She has not, because she hasn't got that 12 months, right? Second question is, so we know she hasn't reached menopause. She hasn't hit that 12 months. So she's got to be on the left side of that scale. The two that are in, we've decided, is she in perimenopause? Put that one in the chat, yes or no. Is she in perimenopause? Yes, 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 yes. Okay, so you got the two biggest and most important things. She's not in menopause, she is in perimenopause. That's probably the most important thing for you to remember. Okay, she is in perimenopause. Now, she's got these vasomotor symptoms, but she's really swinging a lot. She's going back and forth. Okay. So, if we could pull up well, I guess I could pull it back up again. So, yeah, -1 because she's 90 days. Remember? So, -2 is up to 60 days. She's 90 days apart. So now she's in -1. She's really close to that 0. Right. So you made the most important. She is not in menopause. It's that FMP 12 months. She didn't hit that. She did have more than 60 days, right? 3 months apart. And she's got the vasomotor symptoms, which tend to be increased in -1. Perfect. Love it. Love it. Love it. You're starting to feel more with it now. And now our last one is Maya, who is 39, regular 28-day cycles, but she's feeling more fatigue, irritability in the luteal phase. Now we know that's the second half, mild weight gain around the belly. Okay. She denies any hot flashes or skip periods. She's really regular, 28 days. Labs, her FSH is 8, estradiol is 180, progesterone is 5 on day 21. Okay, so that's in the middle of the luteal phase. She has a demanding job, sleeps 5 hours a night, drinks 2 glasses of wine most evenings. I have a lot of patients just like this. So what's your differential? Where does perimenopause fit? And what staging would you ask for? Let's kind of go with the differential. That one I'm actually more interested in. What would be the differential for her right now? Too bad we don't have a CHM contingent. Yes, that would be. Hey, Debbie, maybe we could come up with one of those. That would be awesome. She said, "How about a continuous hormone monitor?" Wow, that would be awesome. So, what would the differential? Look at those things: regular cycles, more fatigue, gaining weight around the belly. Her labs, her progesterone is 5, mid space. Could be depression. Yeah, could be depression. What else? What does she do? Demanding job, sleeping 5 hours a night, 2 glasses of wine, right? Anxiety, PMDD, high cortisol. Ooh, yes, right? She's stressed. Remember, remember what stress does. It wrecks everything. Okay. Remember that no matter what you're looking at or whoever you're speaking with, stress affects every single part of our system. Okay. So number one, this could be, I'm not going to say just stress. this could definitely be stress related. Okay. Because she is ovulating. She's got a progesterone of 5 on day 21. Her estradiol is okay. Her FSH is maybe a little bit up, but not crazy. It's not over 10. So we're okay there, right? She -4 with stress, give her GABA. I love it. Love it. And maybe, yeah, exactly. I love that. Okay. So she really isn't in perimenopause yet, right? She's got regular cycles. Remember, straw plus 10. Regular cycles, they are not in perimenopause. That's it. Look for something else. Okay. And then that's where we would put her. Okay. So here are our key takeaways. Perimenopause is a transition. And congratulations, you all did wonderfully on that. I love that. I love that. It's a transition. The only thing that is abrupt is that the final menstrual period at 12 months. That's it. And then everything else varies around it. Straw plus 10 gives you that framework, but even it is not perfect. Just remember that. Hormonal fluctuations. We talked about bone. We didn't even talk about breast. How did I even leave that one out? Other than saying breast cancer is a possibility. Muscle, we talked about cardiovascular, we talked about insulin sensitivity, all of these things, all of these systems. And then the neuroendocrine and metabolic changes can explain a lot of symptoms that have been dismissed in the past. So, what's one symptom now that you'll recognize differently in your patients? If you would put that one in the chat, I would love to see that one. One symptom that you'll look at differently and recognize, wow, this could be perimenopause. Stress, yeah, mood swings. Love it. Yeah. One symptom. I want some more. What else is there? Increased duration between menses. Yeah, yeah. More than 7 days consistently. We're starting to think perimenopause. Exactly, exactly. Okay, so before we finish, before I say our last thing, what we're going to be talking about next week, I would love if you would do this for me. If you scan that QR code, you can put in Peri, Peri, it will ask you 5 quick questions. And once you answer those, it'll let you download the slides. So you don't even have to look for the slides. They will come to you immediately. Oh, thank you so much. Thank you. Looking forward to next week. Oh, great, great, great. Love it. So yeah, if you would do that for me, it would be wonderful because this is actually, I mean, Katya was wonderful to give this opportunity to teach this class because you can tell I'm like really excited about it. And she gave me that opportunity to do that. So I'd love to hear what we can do to improve it so that we can kind of go from there. All right. And next week, we're going to be talking about lab testing, its limitations. We're going to rule out the differentials that actually look like perimenopause. We will talk about testosterone and the other androgens. We're going to talk about lifestyle and nutrition, the changes that your patients and clients need to make to be able to monitor or manage and go through perimenopause better. And then we'll talk about how do you actually sit down across the table from them and have them understand what you're saying and have them buy into making those changes. So thank you. If you'd like to connect with me on LinkedIn, you can do it that way. And I'm going to stop sharing and just open up for any other questions if there are any.
Yeah, thank you so much, Susan. This was wonderful.
Oh, thank you. Should we be checking progesterone levels when we check E2 and testosterone? Yes, yes. And we will get into that next week. Some of the best tests to do. To follow, if you're on HRT, you're probably going to want to do blood testing. But initially, I do like to look at a different test, and I'm going to leave it open until next week so that you come back. All right, but the short answer is yes. Okay. I don't see any other questions. If there are any. Okay. Very good. Well, thank you so much. If you have anything that you'd like to add, well, hopefully you filled out the little form, and so I'll get some information there. But reach out to Katya as well if you have any specific issues or questions that you'd like to cover in next week. And we'll kind of see you next week. Have I found an optimal P to E ratio in your personal practice? No, it's going to be more the ratios, especially when they're in that perimenopausal stage. Because remember, the estrogen is going like this, whereas the progesterone is going more like this. So it's going to be more a matter of how they respond. um, what I do like to say is that more and more of our studies are showing that you want to give both if there are no contraindications, as opposed to just giving estrogen to bolster up lower estrogen. Okay, hopefully that answered. Um, do you add any hormones when someone is on birth control, like Mirena IUD? And okay, so yeah, so when they have an IUD, you're going to have to look at their blood levels, number one. And then again, just as I was saying with Stephen, you're going to want to look at what their symptoms are. Because if nothing else, you don't want to just treat a lab value. You want to treat their symptoms. If they happen to be low, but they're fine, you're not going to give them estrogen or progesterone, and vice versa. Okay. Good deal. Yes. Am I a fan of pellets? Ooh, I will answer that one next week. That is a big discussion, much more so than we've got time for now. And I'll explain the pros and cons of pellets versus no pellets. And there are different types of pellets. So not all pellets are created equal. So that is definitely next week. And I think that's it. So thank you. We discussed different routes of hormones. Yes, we are going to talk about the different routes. Yep, absolutely. Okay.
Great. Well, thank you so much. Thank you, everybody, for joining. Looking forward to seeing you all next week.
Okay.
All
Bye.
right. Bye, guys. Thank you.